Thank you for joining us. My name is Jenny Pagel-Guile, and I am the Executive Director of the National Pancreas Foundation. Our mission is to provide hope for all of those suffering from pancreas disease through funding cutting-edge research, providing support and education, and advocating for better services and access to care. Some of the impact of the National Pancreas Foundation is awarding over 5 million grants to up-and-coming researchers to keep them in the pancreas field and moving care and treatment forward. We've endorsed over 180 centers of excellence across the country, from cancer, pancreatitis, and pediatric, recognizing that there are needs for all of our patients and, again, elevating the highest level of care. We also provide a variety of programs to volunteers, care providers, and medical professionals as well. There are many ways that you can be involved in the Pancreas Foundation, as well as several resources available online and on demand. We have the animated patient that provides detailed information about the diagnosis as well as the pancreas itself. We co-sponsor Camp Hope with Rebecca's Wish, our first pediatric pancreatitis camp in the country, and we provide nutrition support through our cookbook services and online webinars. All of this information can be found on our website, as well as a listing of all of our active centers of excellence. Across the country, we have over 30 chapters. These are volunteers and individuals who provide support to each other. They also provide grassroots efforts at tabling at local health fairs, providing fundraising support and education. They also sit in on advocacy calls at the local and national level. We would love to have you join us if you are able, or you can start a chapter in your community. Reach out to our staff if you would like to receive more information. Again, we have a full calendar of events, virtual and in person, on our website. We have an assortment of galas across the country. We have patient education events coming up in person, as well as medical professional events. And again, all of our webinars are available on demand online. The best way to stay up to date is to subscribe to our monthly newsletter. We also are on a variety of social media, so make sure that you follow us and share with your community and peers. We would love to have you join us. Now I would like to introduce our next speaker. Our speaker, Tamara Carey, APRN, a graduate of Eastern Kentucky University, began her nurse practitioner career in November of 2016 with the University of Kentucky Surgical Oncology Team. Currently, she is involved in the outpatient clinical services as a part of the multidisciplinary GI team, providing care to a variety of patients with upper GI malignancies, metastatic colorectal malignancies, and benign GI tumors. Tamara is also seeing patients with sarcoma tumors, melanoma, and non-melanoma skin cancers, and high-risk breast patients, as well as the patients with benign breast disease. Tamara Carey is involved in multiple research projects alongside her faculty. Her interests include genetic familial cancer risk assessment with the focus on GI malignancies. She is certified by the City of Hope Genetic Program, and she organized a high-risk GI surveillance clinic in coordination with the genetic counseling team. The main goal of a surveillance clinic is to provide appropriate surveillance, blood work, and imaging tests for patients and their family members who harbor germline mutations. Additionally, she coordinates with the high-risk breast and GYN services and clinics to ensure all appropriate GI surveillance studies for their patients are completed as well.
Hello, my name is Tamara Carey. I'm a nurse practitioner that works at the University of Kentucky Surgical Oncology Division. One of my duties is manage high-risk clinic, where we see patients with multiple cancer predisposition syndromes. My main focus is gastrointestinal cancers and pancreatic surveillance clinics. I'm a paid employee of University of Kentucky Market Cancer Center. That's all disclosures I have. The objectives of this presentation would be to discuss inclusion criteria for genetic testing, describe basic concepts of high-risk pancreatic surveillance program, and discuss management of patients at high risk for pancreatic cancer. This slide shows a commonly seen information that most likely you're familiar with. So as you could see, there are chromosomes that pictured here. Chromosomes every cell in our body contains chromosomes. There are 23 pairs of chromosomes, with the last pair looking somewhat different compared to the other 22, and those are sex chromosomes. One pair of chromosomes contains genetic information that passed down from biological mother, and biological father contributes another set of chromosome for the individual. If we further look under the microscope, we could see that each chromosome has a very neatly packed DNA in the nucleus of the cell. DNA is our genetic information that is very personal to all the human beings, and that's when we genetically test patients. We compare their genetic information that we obtain from the patient to a known genetic code, and the difference in between the known genetic code and the patient can help us to determine if patient has pathogenic mutations or genetic syndrome known for that particular mutation. The distribution and types of cancers usually follow three categories. The most common category is sporadic, where cancers occur sporadically in a person. About 10 to 20% of all cancer cases include familial distribution, where we know that family has genetic testing before, and it's known that multiple family members have gene mutations responsible for certain cancers in those families. There's also environmental exposure potentially can be present in those families, resulting in a genetic mutation. And in those families, multiple family members are affected by certain types of cancers that basically describe a genetic syndrome. If we look even further down into those familial traits, then we can determine 5 to 10% of those families actually have a true hereditary pattern of inheriting the cancer. That's where those family members pass down genetic mutations that will qualify them to be in a certain genetic syndrome category. Cancer risk factors is a multifactorial assessment of the patients. If we look into each patient, we should include assessment of the family history of the patient. How many family members are affected by cancers in these patients? Are they all on the same side of the family, or different sides, or if there's a certain pattern of those family members being affected by cancer that could potentially represent a certain genetic syndrome. Environmental exposure. Is this person coming from the area where it's heavily polluted by example of coal mining or oil rigging, or if there is a heavy factories presentation that affects the environment of those of the people there? Are there known cancers that coming from that area we see over and over? Then we'll look at the lifestyle. Is patient obese and active? We know that for a lot of, for example, for females, obesity and inactivity increases the risks of female cancers. Do they abuse alcohol or tobacco? We know that alcohol and tobacco are connected to increased risk of liver, esophageal, and pancreatic cancer. So all of those factors needs to be included. And of course, we look in genetics, as I mentioned before, familial genetic history. If there's a family member that was tested before and with known pathogenic mutation, we'll always wonder, is this family member is also affected by the same gene mutation? aging is also known to unfortunately increase risk factors for cancer as we age. It's kind of cumulative effect of aging of our organs, previous lifestyle, previous exposures, and of course weakening of immune system with aging can potentially increase someone's cancer risks. And there's always a chance. Is this just a sporadic occurrence of the cancer in this individual? Occasionally, we see individuals that are completely healthy. They did not have any family history, did not have unhealthy lifestyle, such as alcohol or tobacco abuse. They develop pancreatic cancer. So there's always a chance of sporadic mutations for those patients. What would be the common indicators for genetic testing? Anybody who is diagnosed with cancer at a younger age, less than 50 years old, we should always think about potential genetic mutation in this patient. Rare cancer, ovarian, male breast, or pancreatic cancer, it's a big red flag for those individuals to be tested. Multiple cancer in one patient, multiple primary cancers are always suggestive of genetic mutation and potentially syndrome present in this patient. And the family members, are there two or more family members on the same side of the patient's family that are affected by related types of cancer to a specific syndrome? For example, we know BRCA mutations, families affected by breast, ovarian, pancreatic cancer. For Lynch syndrome, there's multiple family members that are affected by colon cancer, uterine, sometimes pancreatic cancer. So all of those questions and assessments need to be done in this patient to for them to be referred to genetic counselors for further testing. Once we get genetic testing results, after the assessment and testing is done, we get a certain genetic information from this patient's genetic testing. So one could be positive for pathogenic mutation. So usually that is a certain gene that's affected. And in the report, it specifically states which gene is affected by the mutation. So based on that information, we determine which medical management based on that genetic mutation is offered to the patient. Then there's also a variant of the genetic mutation that's likely pathogenic, which means we have enough data to be concerned about this genetic mutation being linked to a certain cancer or a certain cancer syndrome. So those patients also managed by guidelines for that specific mutation. Then we have a big gray zone of variants of unknown significance. So those patients with those results, we kind of leave them in the gray zone of not really knowing exactly where they're going to end up. So those patients we usually manage based on the family history. If there is a significant family history of certain cancers, we manage them depending on that. If there is no family history, then we leave them in the database and let the patients know that database always gets updated. It's very fluent. We always accumulate data. It's ongoing data accumulation, and sometimes we do bump those variants of unknown significance to actual pathogenic mutation, and so those patients notified about that, and then the recommendations of surveillance and management are given to those patients. And there's of course negative results where variants can be benign and there's no variants detected. That means the genetic testing has been negative. And for those patients as well, we manage them based on their family history and their personal health history. I want to talk about somatic and germline testing. A lot of times, this testing is being used interchangeably. So let's talk about somatic testing. So somatic testing is done on the tumor tissue. So it only identifies mutations in the tumor. The tumor tissue collected either during a biopsy or diagnostic procedure on the patients that were concerned about having cancer. Germline testing is identifies mutations in the germline. Those mutations that we're born with. The collection for germline mutation comes from either collection of the saliva or blood from the patient. As I mentioned, the somatic testing only performed on the tumor tissue, and germline is on blood and saliva. Majority of patients that undergoing tissue testing, there's either a very high concern for cancer or they have cancer. For germline testing, patients can be unaffected and basically go and work up for significant family history of cancers or known genetic mutation in one of the family members. Somatic testing of the tissue helps medical oncology identify treatment options and determine prognosis of that patient. Germline testing helps us to identify patients with inherited cancer predisposition syndromes and manage them appropriately, hinging on that. Most somatic testing is ordered by oncologists unless there is a reflex testing from the tissue biopsy per every institution policy. And germline testing is most times ordered by genetic counselor after the consultation. And occasionally that can be ordered by oncologist, surgeon, or primary care provider if genetic counselors are not available. For somatic testing, patients do not consent. And for germline, patients do consent for germline testing after the consultation. One thing to remember, regardless of the results of somatic tumor testing, if somatic tumor testing does show certain mutations in the tumor, this does not mean, those findings do not mean that patient will have a germline positive result. Regardless of somatic tumor testing, if there is a high concern of the patients having genetic syndrome, we should send them for genetic counseling, and they should undergo germline testing. What are advantages and disadvantages of testing? So advantages is change of management and surveillance options of those patients that tested positive for certain genetic mutations that will predispose them for certain types of cancers. Also, for cancer patients with germline genetic mutation, there could be potential change in treatment options. A lot of them qualify for immunotherapy, such as Keytruda, which for other patients without genetic mutations, they may qualify just for chemotherapy. We can consider risk-reducing surgeries for those patients to prevent cancers. For example, for BRCA mutations, we can offer risk-reducing mastectomies or oophorectomies to reduce the risk of breast cancer or ovarian cancer. We can manage them more conservatively to reduce risk for a secondary cancer. For example, for lymphoma patients, there is known avoidance of radiation, as we know the high risk of angiosarcomas as a secondary cancer. Patients want to help their family members to reduce their risk to develop cancer. If they do have genetic mutation, they can undergo proactive surveillance and management. And simply, patients want an explanation for why they develop cancer, what has happened, what's responsible for their condition. On the other hand, genetic testing, positive genetic testing can produce a lot of anxiety and worry associated with lifelong screening and high-risk visits, guilt for passing on mutation to their children, uncertainty that comes with findings of VUS, which basically, like I mentioned before, leaves them kind of in the gray zone. Costs, cost of surveillance, costs of imaging could be very bothersome and produce a lot of issues for those patients. And of course, there's some issues that can arise with life insurance, obtaining long-term disabilities because of the past genetic testing. So we always have a very good consultation with the patient, requiring them to understand the pros and cons of genetic testing to make sure that they're ready for that they're agreeable to undergo the genetic testing and what it's all entails to them, and what their future looks like if they have a positive genetic result. Why do we have a high-risk clinic? I feel like genetics is the hottest topic in the modern healthcare. It's growing fast. We're detecting more and more patients with genetic mutations. We need the clinic that can provide those services to be able to take care of those patients. The patients that are affected by genetic mutations, they need different screenings than those at average risk and more frequent surveillance. We need to follow on change in recommendations on the management of those patients. High-risk clinics help with early detections, improve survival rates, and reduces treatment burdens on those patients. Center care, where we can provide centered approach and multidisciplinary approach to this patient's care, where we can provide quick referrals to specialties, arrange needed imaging and procedures, and to assure that patients undergo timely and appropriate screening and management. The logistics of high-risk clinics is usually an outpatient setting. We could perform telehealth and in-person genetic counseling. The key team members is medical doctors, advanced practice providers as the primary coordinators of care. Genetic counselor is a huge part of high-risk clinics. They provide risk assessment and genetic education. And then we have multidisciplinary providers such as gastroenterologists, oncologists, and surgery if needed. And then, of course, we always provide services of nutritionists and psychologists, social workers to address lifestyle and mental health aspects of those patients. At UK, we have high-risk GI program that open to multiple syndromes. We see patients not just for GI purposes, but also for whole body surveillance. We follow protocols that developed by NCCN guidelines for management and risk assessment. Main goal of high-risk clinics is, of course, early detection, as I mentioned before, risk reduction with appropriate surveillance modalities. And we provide multidisciplinary management with close collaboration with high-risk breast, gynecology, and genetic counselors. Inclusion criteria for high-risk clinics, known cancer syndromes such as BRCA mutation or multiple genetic alterations that put people in, for example, Lynch syndrome category. Increased risk based on the family history, patients with parent and siblings with pancreatic cancer, will qualify for high-risk surveillance, and of course, increased risk based on personal risk factors. It is a known fact that patients with history of chronic pancreatitis are at high risk for pancreatic cancer, therefore they will qualify for surveillance. Here is the quick chart with most commonly seen gene mutations that we see here in clinic. I highlighted the ones that we surveil for pancreatic cancer. And on the next slide, I put it all down to where all the pancreatic cancer screening criteria. So as you could see, patients without genetic mutation has to have certain family history where 2 or more relatives on the same side with pancreatic cancer, with at least one being first-degree relative, or 3 or more second-degree relatives with pancreatic cancer on the same side of the family will qualify for pancreatic surveillance. Usually we start at age 50 unless there's a younger first-degree relative that could potentially, we could start 10 years before that age. There are certain gene mutations that, regardless of family history, will qualify patients for pancreatic surveillance. As you could see, the ATM mutation, BRCA2 mutation, the melanoma pancreatic cancer syndrome, CDKN2A mutation will qualify those patients, and ages of the screening for those mutations are different, and we follow that or the family history. So we start 10 years prior the youngest age of pancreatic cancer family member. And then there is some mutations, some mutations that do require family history of pancreatic cancer. As you see, BRCA1 is actually in a category where patients do have to have a family history to qualify for pancreatic surveillance. There's Lynch syndrome, gene mutations, and most of those mutations that under the Lynch umbrella will qualify patients with the family history of pancreatic cancer for surveillance. For pancreatic cancer surveillance, we use different modalities, such as imaging, which include annual abdominal MRI or a CT scan if MRI is not possible to perform on the patient, and endoscopic ultrasound of the pancreas. My preference is to start with less invasive modalities such as imaging, and then depending on imaging results, we always have a very detailed discussion with the patient about further steps. We always talk about endoscopic ultrasounds, that they are not a benign procedure, and you have to go under anesthesia. So if patient's completely asymptomatic and their MRI shows completely normal findings of their pancreas and their blood work is normal, then we usually discuss with the patient and give them a choice if they choose to proceed with endoscopic ultrasound for further workup or defer until there's abnormal imaging that comes up at the next visit. Majority of patients will choose less invasive options, such as MRI, the CAT scan for their surveillance, and blood work. Pancreatic screening, other consideration for the high-risk clinics. Screening and management of those patients is very complex. We do recommend for them to undergo their imaging in the high volume centers where we have a very good quality equipment, radiologist that's specifically assigned to abdominal imaging, and a specialist that's available for further workup. Screening limitations for those patients can be associated with multiple factors such as cost of the screenings, time to wait for example to undergo endoscopic procedures, or travel or taking off work multiple times. So all of those things have to be coordinated, and a lot of times we try to accommodate patients to where they don't have to travel multiple times to the center or take a lot of time off work. And then each visit with those patients, we have in-depth discussion and education regarding their signs and symptoms of pancreatic cancer. We use simple language. We don't use medical terms to describe when and how to report to us what the concerning symptoms, how long they should persist until the patient contacts us. And we do discuss this at every visit. And of course, we always encourage patients to live the healthiest lifestyle as possible. We talk about the obesity management, exercise. We provide counseling if patients is interested in nutrition to make sure that patient consume healthy diet appropriate for their age and weight. And of course, we always counsel on avoidance of alcohol, smoking, and we provide services to help patients, the ones that interested in either stopping tobacco use or alcohol use, to those patients with social worker support and tobacco cessation program. In summary, I just want to kind of bring the several points from this presentation. Please think about sending patients for genetic testing if patients diagnosed at young age, before age 50, or they have multiple primary cancers, or they have rare cancers such as pancreatic cancer. Families can have more than one hereditary cancer condition. Remember, one set of chromosomes comes from mom, and another set comes from the dad. So one of the sides may potentially have a different genetic mutation, and they can pass down to the patient one or two or more different genetic mutations that could predispose them developing multiple cancers throughout their lifetime. Remember, not all family histories will make sense with the mutation that would be found on the genetic testing. There's plenty of times I was very surprised to see the mutation that was determined after the genetic testing, just based on the patient's personal and family history. Panel testing is important. We rarely test for just a specific genetic mutation, only if there's known genetic mutation in the family, in the first degree or second degree relatives in that person's family. For example, if there's a mom with a BRCA mutation, then and we're only interested in the BRCA testing per patient's request, then we'll test that. But usually the wide genetic panel is offered to the patient, so we could test for multiple genetic mutations. And we always try to send patients to genetic counseling prior offering testing, so the patient can discuss all the caveats, cons and pros of genetic testing and potential results, as it could become very complex. And then I want to bring again the home run for high-risk clinics. High-risk clinics, I feel like is a very important part of the healthcare that we provide to the patients with the predisposition syndromes and the ones with the significant family history of pancreatic cancer, because we provide potential for early detection of the problem, continuity of surveillance services, and the provider that manages those patients could be someone who will take care and provide the continuity of medical care for this patient for a lifelong services. And then, of course, multidisciplinary approach. with multiple specialties, genetic counselors, radiology, other high-risk clinic participating in the care of these patients. It makes a huge difference for the patient to be taken care in the centers that that's basically focused on providing those specific services, and the timely referrals are also sometimes can be just life-saving saving modalities for those patients. And that I want to thank you for everybody for the attention, and thank you for your time. There's my references.